Most oncological therapies come with some toxicity, so there's no doubt about that at all. I think the ERA 223 trial is a good example of why you need to do big trials in order to identify toxicity. What it also has identified is that people are not following the guidelines from previous research which show that bone health agents are important in this group of patients. So it is disappointing to think that patients were treated in this trial only about 40% of them received a bone health agent, which really isn't high enough. And if the guidelines and the evidence base had been followed, almost all the patients would have received bone health. So there certainly is a problem in disseminating this kind of information from large randomized trials into clinical practice and into patient benefit. I think overall though, when it comes to weighing up decisions, we have to have an evidence-based approach. And I guess there's a hierarchy of endpoints. So if a drug is improving overall survival, we pay a lot of attention to that because it's altering the natural history of the disease, allowing patients to live longer. But for sure we have to balance that benefit against the risks. And most patients will accept quite a bit of toxicity if the payoff is improved survival. But in my clinic, and I think generally it's very important to consider the quality of life. There's no point extending somebody's life if either the toxicity of the treatment is so severe that they can't enjoy their life, or indeed that the quality of life that they have just in general, that they might have a longer survival, but actually their disease is still fairly prevalent and they're not really experiencing a disease-free interval. So I think when it comes to talking to patients, we have to have evidence base. When I talk to patients about a new therapy, hopefully I'm talking about one which has been proven in a randomized trial and perhaps even proven in further randomized trials. And when it comes to the guidance, the guidelines that are published by the various agencies like ESMO, ASCO, etc., they should be evidence-based and they should be practically of value to the clinic. I think they should be achievable for patients, especially for the ESMO, should be for the European population. It should be feasible to receive these treatments.